Welcome to the VA Boston Healthcare System. Thank you for your interest in our protocol. My name is Gary Gramigna. I work here in the Speech Pathology Department here at VA Boston Healthcare. And our purpose today is to show you a little bit about what we do procedurally when we prepare to do a video fluoroscopic swallowing study, or what we like to call a VFSS. What I'd first like to show you is some of the equipment that we use for this study. If you will take a look over in our control room over here, you'll see some of the equipment that we use for our current digital image capturing. What we have in there is we have a computer processor, monitor, and we have some cabling attaching the fluoroscope to the computer processor. We use this system now for our digital image capturing. That allows us to do more manipulation in addition to our analysis and storage of the images that we capture here in the VFSS studies. We used to use a videotape analog system, which we still have in the control room as a backup for any kinds of problems that may occur with this system. But we're very happy with the system as it's currently constructed. Okay, now what we'd like to do is show you a little bit more about what we do in terms of the setup for the conditions that we administer when we do the video fluoroscopic swallowing studies. On the barium conditions, we have Kelly Gardner. What Kelly's going to do is show you a little bit about how we do mix the barium conditions. We're always after trying to standardize things as much as possible. Our first condition is a thin liquid condition. And what we want to do there is we try to use 50% Easy Pake thin liquid from EZM and 50% water. We do have measurements on the cup to make sure that we get it 50%. Sometimes we will try to make it more natural. We'll try to pour the mixture that we have in this cup into a more traditional styrofoam 8-ounce cup, which might be more likely what the patient may see when they have their meals. The second condition is a nectar-thick liquid barium product called Veribar, also from EZM. And the benefit of this product is it's pre-mixed to a nectar consistency, and this we feel does give us the standardization we're after in terms of the viscosity. We try to use about 50 milliliters of thick liquid condition, or at least enough to get 2 or 3 teaspoonfuls. The third condition is a Veribar barium pudding, also from EZM, and also pre-mixed. The same amount as the nectar thick condition, about 50 milliliters or so. And again, we want to have about 2 to 3 teaspoons available to utilize for the study. The final condition is a graham cracker cookie that we coat with the barium pudding. We usually use 1/4 of a cookie, and we utilize the graham cracker because we feel that that does give us the opportunity, if somebody is edentulous, they can still perhaps manage that. In addition, if they can't manage it, it will soften, and we utilize that condition as our last image in the lateral view. Okay, welcome back. What we'd like to do next is show you a little bit about what we do in information gathering right before we see the patients here for the video fluoroscopic swallowing studies. Before I do that, I just want to talk a little bit about radiation safety. You see that I'm currently wearing the standard issue lead apron and thyroid shield with my dosimetry badge on the outside of the thyroid shield. This is standard precaution for radiation safety. In addition to these items, one can also wear radiation goggles for the protection of the eyes, or there are ring dosimeters if there was any concern about the hands as we do administration being near the field. But for right now, we have a sample patient that we'd like to review some questions that we asked right before the study. How do you do, Ms. Kelly?
Good morning. How are you?
I'm fine, thanks. How are you today? My name is Gary Gramigna. I work here in the VA Boston Healthcare in the Speech and Swallowing Department, and you're here today. We're going to do a little assessment of how you're doing with your swallowing. Do you mind having a seat right there? Okay. Before we get started, we have our camera right here. We're going to use a light X-ray to take some pictures of the muscles that you use for swallowing, and see how they're working, and basically try to see if there's anything that we find that will help with your situation. What I'd like you to do, if you could, is tell me a little bit about what kind of problems you've been having with your swallow.
Sure. I guess I've been coughing a little bit during the meals. It's more towards the end of the meal. solids and liquids have both been kind of causing problems. And I feel like it's sticking in my throat, kind of right about here.
All right, so let me make sure. You do feel something sticking kind of right at the base of your throat there? You're pointing
right
to it
about
right
here.
there? Okay. When did you first notice the problem?
I guess about 3 months ago it started.
Okay. And since you first noticed it, has it gotten any better or worse or about the same?
Yeah, it's gotten worse, yeah.
Okay. How often would you say you have the difficulty?
Not every meal, but it tends to happen more at like the end of the day when I'm kind of tired. Those meals, like more like dinner or if I have a late lunch or something.
Okay. Well, thank you very much. We're going to get started in a second, but
Okay.
before we do, I did want to mention, she mentioned two things that would be very important things for us to remember as we're about to do the swallowing study protocol. She mentioned about the food sticking at the base of her throat. And that's very important to us because there is some information in the literature. Jones and Donner in 1985 did a study of some 40 patients with uncertain pharyngeal dysphagia, and they found about anywhere from 25 to 35% of the patients either had esophageal problems masked as pharyngeal problems based on clinical history and description, or they were able to find a combination of both pharyngeal and esophageal problems. And our experience here at the clinic is very similar to that. So we do want to pay attention then, because of that reporting of sticking at the base of the neck and the way the enteric nervous system refers pain up, we know that the problem may be there or it may be below there. And that's why, one of the reasons why we benefit from having the radiologist present when we do these procedures, in case we want to look a little further down. The other thing she did mention was that she did have more trouble at the end of the day and sort of indicated that there was some fatigue. That's important because we may want to change our protocol, our standard protocol, as you've read about and described. We may want to stress her a little bit more and try to elicit a little bit of the fatigue to see if that does change the swallowing function in any way. At this point, I need to ask you, is there any chance that you may be pregnant?
No.
Okay, well, just in case, because of your age, we're going to have you line up in front of the camera here. And John here, our radiation technologist, is going to give you just a little bit of extra protection. We're using a special lead apron for the patient, and you notice that John is placing it on the side. And what I'm going to have you do, Ms. Kelly, is just step back for me a little bit. I'm going to come over here on this side. I'm going to pull out the fluoroscope, and we would normally get things lined up here, and I'm going to use this towel in case we spill anything. Usually pretty good. But the lead apron is on that side because that's the side that the radiation is actually coming from behind, from here, out to the image intensifier. And so, so that is the way that it will give her the most protection at this point in time.
You will now view some standard imaging from the lips through the UES.
Go ahead and swallow. Keep it all on the field. Go ahead and swallow. 5 cc thin liquid, swallow number 1.
Now you're seeing
Go ahead. Cup drinking.
a patient receiving the protocol. First 3 cc swallow, then a 5 cc thin liquid swallow, and this is a cup drink swallow condition. We're trying to challenge the patient a little bit with the cup drink to see if we can elicit some difficulty, and also
thick liquid, swallow number 1.
the cup drink is an attempt also to represent a more natural condition.
Swallow. 5 cc pudding thick, swallow number 1.
We saw 5 cc thick liquid, nectar thick. Here is 5 cc pudding thick swallow.
Go ahead and swallow again. Good.
We use a medium magnification
Go ahead and swallow.
and continuous fluoro for the study.
Number 1.
We also announce the conditions as you hear. We have a microphone in place. This can also capture if the patient were to cough as a result of aspiration. We do see this patient has some difficulty with clearing the food material orally. You may have also noticed some prominence around the upper esophageal sphincter during prior swallows. After we complete the lateral condition, we would like to turn the patient into an anterior-posterior view, which you see here.
Go ahead and swallow.
This is to look at the symmetry of the swallow.
Number 1. Now
traveling
just
down
look
both
straight up
sides
in
of
the
the
air and say,
throat.
ah, 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 ah.
The
Very
final
good.
condition is vocal cord.
Look straight ahead and just swallow.
Vocal cord view producing an ah,
Okay.
repetitive ah, ah, ah.
All right, very good.
To help us document our analysis findings, we use something we affectionately call the Video Fluoroscopic Evaluation Worksheet for Swallowing, or the VIEWS.
The study you just viewed was a 92-year-old male. The analysis shows a mix of normal aging changes with some oral stage findings. The VFSS is a physiologic standard as it provides the most biomechanical information as a single study on oropharyngeal swallowing function. Thank you again for your interest in our protocol.